You gotta have that, otherwise, you know,
Yes.
somebody's gonna facilitate the discussions with those practitioners.
Yeah, that's critical.
Yeah.
I'm glad you brought that up, yes, Hattie.
At least for the Medicare age population, the Medicare stars financial incentives.
Yes, and any way that we have tried to, any way we can match up with quality incentives, whatever those are, yeah, in whatever population. Okay, I'm being told I'm getting the hook here. So I'm going to turn it back over to Susan. Thank you so much. If you would you just put those in the middle of your table and then we can collect them? And I am doing a systematic kind of data collection for this, so thank you very much. I appreciate it.
Thank you. Switch us over to Rose's slides. So our next speaker is Dr. Rose Pavlakos. She's going to talk to us about managing hypertension through innovations in technology. Rose works with Dr. Marilyn Stebbins, who spoke with us before about some of the programs at UCSF. We have been following some of the hypertension technology work that Marilyn's been doing, but we haven't heard the outcomes yet. So Dr. Pavlakos is going to talk with us a little bit about that, and then she's going to talk some more about this issue that we're all talking about, which is what do you do to get the data into the medical record, which a lot of us are facing, these interoperability issues. Dr. Pavlakos is a PharmD and has board certification in the ambulatory care pharmacy. We've been hearing about some of these board certification processes that sort of mirror how, you know, physicians are trained. We go to medical school and we do residency and we get boards in different areas, and so pharmacists have a very parallel process now. She's a clinical pharmacist at UCSF.
It's hard for us to hear you unless you're up.
She began her work with the Department of Clinical Pharmacy and the Division of Cardiology in 2016. And during this time, she's been helping to develop and expand clinical pharmacy services and splitting her time between UCSF's outpatient cardiology clinics and teaching at the school of pharmacy.
Thank you all so much for having me today. I know that you heard a little bit about this project last year when Marilyn Stebbins and Rajni Rao came and presented on it. I'm going to present it with a little bit of a different take and give you our results that I don't believe you heard last year. So I want to start off by talking about technology in general. When I moved here 2 years ago from Ohio, I never thought that I would be ordering my groceries and having them delivered to my front doorstep. I also didn't realize that maybe when I'm tired and don't feel like going out to dinner, I could just get on my app and order from any restaurant in the city and have it delivered to my home. I even saw something online the other day that they're developing, too many touches
Did
here.
that earlier too.
There we go. Don't touch anything. They're now developing this drone that's going to deliver prescriptions from pharmacies to the patient's home. And so I did some research and I found out that now there are over 160,000 health-related platforms available via Apple and Android app stores today. And that to me is extremely intimidating. I mean, it's hard enough for us to keep up with all of these changes in healthcare, much less keep up with all of this new technology. So I wanted to start off my talk today by asking you a question. When you hear the word technology, how does it make you feel? For me, when it comes to technology, at some point in time I felt all of these emotions. And then I started to reflect and I realized that the different emotions that you're feeling as you're starting to try out new technology are really similar to those described in the Kubler-Ross change curve depicting the 5 stages of grief. And I know this wasn't really developed to describe this, but it does a really great job of explaining how we all react to change. So if you think about it, let's all imagine for a moment that we are getting a new electronic medical record today in our clinic, and we have to somehow do our job just the way we normally would. At first, we're going to be very fearful, maybe anxious, we're going to get really overwhelmed at some point, and then we're going to start to get used to it, and we're going to be like, hey, maybe this isn't so bad after all. And then, finally, we accept the change, we're really good at it, and then guess what? The next best thing comes out, and we have to do it all over again. So love it or hate it, I mean, this is a reality. We've entered into a field where change is constant, and where technology is now becoming an integral part of our care that we're providing for our patients. So I think it's really important that we all step up and try to utilize these technologies to help benefit our patients. And so we did just that with our project 2 years ago, but rather than utilizing existing technology, we sought to help design a product that would help meet shared needs for improving hypertension management. So, as we all know, traditional management of hypertension in the outpatient setting can pose some major challenges for providers, for patients, for payers. So in an ideal model, this is what high blood pressure management would look like. The patient would come in, they're diagnosed with high blood pressure, they'd be provided with extensive education as to what this means. They'd be sent home on new medications, asked to monitor their own blood pressure readings and record them for us, and then come back in 1 to 2 weeks for follow-up and labs. But in reality, and in our situation here at UCSF Cardiology, our providers have maybe 15 to 30 minutes with their patients, limiting the time spent on patient education. Follow-up in cardiology is 6 months out, so there goes that 2-week follow-up. And then we never really know what to expect when our patients come back. Some patients come back to the clinic with no blood pressure readings at all because they tell us that they weren't able to afford their home blood pressure monitor. Others come back with documents like this where there's just so much information you don't really know, like what they ate for breakfast, what they did at 9 a.m., at 3 p.m., at 4 p.m., every single moment of the day. There's other patients that bring in documents like this and you can't really read it. You don't know if the 9 is a 6 or a 4. And then there's other patients who are really tech savvy, and we love these patients, and they send us their Excel spreadsheet and their average blood pressure readings over the past month, and they tell us all of these wonderful things, and this makes it a lot easier for us to decide on future therapy, right? So the Division of Cardiology for many years had been utilizing this traditional model, and they realized that it just wasn't working out for them. They have over 12,000 patients every year, with more than 7,000 of those patients qualifying for guideline-driven blood pressure control. And on top of their billions of other roles that they're performing, they just felt like they needed help. So what they did is they teamed up with 3 pharmacists from the School of Pharmacy over at UCSF, as well as a mobile health platform. And their goal was to study the best prescription for out-of-office management of hypertension. And so they met regularly to help develop and create this app, which was driven by patients' home blood pressure readings. So their workflow essentially was as follows. When a patient came into the clinic and was diagnosed with high blood pressure, the provider was instructed to input what they felt their goal blood pressure reading was into the EMR so everyone had access to it. Next was the provider would offer them the ability to participate in the study, and once approved, the provider would come pull me in and come grab one of the nurses and bring us all in the room and explain to the patient, this is your team. And they would introduce us and explain to them that we would be working together to help manage their blood pressure. Next was onboarding. So onboarding either took place in our clinic or remotely, and during the onboarding process, the health coach would basically show them how to upload the app onto their phone, teach them how to use the app, make sure they knew how to check their blood pressures correctly at home, and they were provided with a home blood pressure cuff to use, complimentary, and once they opened up the app, this is the first thing they saw. So they saw that care team that the doctor had introduced them to, as well as a description of the role of those team members and how to contact each one of them. So next was the baselining period. And this was the time that was spent in the patient's home collecting data for review. Our patients were asked to check their blood pressures twice daily in the morning and evening, and their health coach helped them in setting an alarm on their app to remind them to check their blood pressures at whatever time was most convenient for them during the day. The patients would then manually enter their blood pressure readings into the app itself, and as you can see here, they were able to compare side by side what their current blood pressure was compared to their goal blood pressure. They could also see weekly and monthly averages here as well. Within this setting, they were also able to leave us little notes or comments. So if their blood pressure was 200 over 100, but they forgot their medicine, they could actually write in there, I forgot to take my medicine last night, and this is probably why my blood pressure is so high. this is where us pharmacists came in. So after about 1 to 2 weeks of collecting data, once we saw that there was enough information in the system, the health coach would notify us pharmacists that it was now time for an initial follow-up call. During that initial follow-up call, we would complete comprehensive medication reviews. We would help to answer any questions that they had about their medicines. We would provide them with education that they needed, and then we would review their blood pressure readings with them. We would come up with what our recommendation was and have a discussion with the cardiologist. But guess what? This time, instead of having these readings, we had a beautiful chart or graph, whichever we preferred, that showed us what their average readings were, what it was in the morning compared to the evening, and it made things a lot more simple. Mind you, this was not in our electronic medical record. It was in a separate record that we would have to log into. So we would discuss those changes with the cardiologist, and upon approval, we would notify the patient, provide them with instructions, and follow-up would be scheduled within the mobile health application itself. So one thing we learned from this, it sounds really awesome, but as we were developing it, all of those emotions started to happen again. It wasn't easy at first, but what we really learned from this entire process was that team-based out-of-office management of hypertension is really an option, and it was desirable by our patients, and it led to really rapid control of blood pressures. So as you can see here, after 6 months, we had 123 patients in the study. 84% of them had met their JNCA goal. It took on average only 17 days to get them to goal, and they stayed within goal 74% of the time. We also looked at patient satisfaction with a net promoter score of 38. So what we really found was that this technology helped us to increase the achievement of blood pressure control, and it did it quickly for us. Our patients were able to reach their goals very fast. What we also found is that despite their age, they were able to safely and effectively engage in this mobile health technology. And I think that one of the things that was very useful was that the fact that we were able to all communicate a lot better, and this helped the patients to become engaged. They knew that I, myself, or one of the other pharmacists, or their health coach, that one of us was on the other end of that app looking at their blood pressure readings, and that we were going to do something about it. And I think that really helped with patient engagement. And I think one of the major key components that we found was a success for us was the fact that our cardiologists introduced us as team members, and that really helped to create trust and comfort with our patients. And now there's even literature suggesting that when you have a pharmacist-patient relationship, and when you're able to provide quick feedback on these blood pressure readings, that may be what's helping you achieve those goals. So shortly after I started, I will say that I got hired because of the results of this study, which is awesome. I started working with them 3 months into the study, and 3 months after I started, unfortunately, that's when the elections happened and the mobile health platform lost its funding. So I was back to low tech. What do we do? And I had to somehow transition all of these patients who loved this back to reality of, how do you want to send me your blood pressure readings? Do you want to write them down? Are we going to send them through my chart? What are we going to do next? And so for the past year, I've been working really hard to kind of use what we have. Our electronic medical record should be able to do something like this for us. We just need to figure out how to do it. And so I have put together a proposal that IT has been working on for over a year, primarily because they got caught up in some other big projects that they were forced to participate in. But we are now working on a patient flow sheet, patient-entered flow sheet. So if you all use Epic, as you know, when you look into the vitals and you see our flow sheets of all the blood pressure readings that we've taken, my goal is to have a patient-reported flow sheet where it also shows their home blood pressure readings and where they're also able to leave comments. So we have created this. We're just still in the process of getting it running. This is our flow sheet for our congestive heart failure patients that we're already using. It's just a questionnaire asking how their blood pressures are doing, how they're feeling, are they feeling short of breath, all of these things, and we give them this to them when they leave the hospital. My goal is to do the same for hypertension. I've created these questions so that when a provider orders this questionnaire or the flow sheet, before it goes to the patient through a MyChart message, we can basically decide, within how many blood pressure readings do we want to be notified. If the systolic blood pressure is over 200 or below 100, I want you to notify me. And we would be sent an in-basket message directly once the patient put their blood pressures into the system. And so this is what I'm currently working on. I've described to IT and I'm really pushing towards this proposal because we can't continue our research and we can't continue to evaluate how we're doing if we don't have discrete data to work with. And I think that this will help us to create that ability to do that. So I just want to talk a little bit more outside of blood pressure management about what a pharmacist can do within cardiovascular care. I was hired on 40% and the cardiologists were like, I don't really know what you're going to do here. And now I'm 80% and we just hired another pharmacist. So there are so many things that we can help you with and so many things that I've done since I've gotten there, but I'll just give you a few examples. So when I first got there were a billion efficiencies that were terrifying related to pharmacy. For example, they were still using paper prior authorizations and looking through this list of papers, and I was like, what is happening? So we got them onto an electronic prior authorization process, and I trained the entire clinic to do so. We are now doing transitions of care work with our core clinic, which is Cardiac Outpatient Recovery Clinic. For our heart failure patients who are at very high risk leaving the hospital, we're helping to do med reconciliation with them once they leave and make sure that they actually understand what just happened to them after they leave the hospital before coming in a week later to see our nurse practitioners. And overall, I provide medication therapy management. I help with de-escalating for patients who are on too many medications. I help with drug information questions. We get billions of calls throughout the week of patients who are just started on these high-risk therapies that they really need to be on, but they're having side effects, and now they've stopped taking them on their own, and they need someone to talk to about it. So if you want to hear any more about what I do in cardiology, I'm happy to tell you about it. I'm obviously very passionate about it, but this is the work that we've done so far. Thank you for having me.
Thank you for joining the California Cavalry.
And I'll just keep us rolling, but I'm going to bring us back to do Q&A for both Rose and Stephanie at the same time. So our next speaker is Dr. Stephanie Roberts, also a PharmD and a board-certified pharmacotherapy specialist. She received her doctorate of pharmacy from UCSF in 2012, and currently she is a clinical pharmacist working at UC Davis Healthcare System at select outpatient primary care clinics. In this role, she's responsible for assisting with the development and implementation of pharmacist-led clinical services that aim to ensure effective, safe, and affordable medication use.
Thank you so much. Thank you all. So today, as you can see, I'm going to be speaking on the effect that pharmacist-led comprehensive medication management can have on chronic disease state goal attainment, which we saw among our type 2 diabetic patient population within the UC Davis healthcare system. So no conflicts here, and just the hopes for today's talk are to really identify disease state goal attainment rates that improved at UC Davis outpatient clinics after embedding pharmacists on the primary care team, and also to list future steps being taken at our institution to expand the pharmacist role in the primary care setting. So you've heard this a lot today, but there is a need for pharmacists in the primary care setting. Medications are involved in 80% of all treatments, and nearly 70% of Americans receive one or more prescription drugs, with up to 50% having taken a prescription drug in the last 30 days. So not surprisingly, with these high rates of medication use, it's critically important that management of medications is done properly, because that's key to positive outcomes. We do know from the literature that 1/3 of adverse drug events lead to hospitalization, so again, increased utilization of our expensive healthcare system. Only half of all patients are adherent to prescribed therapies for chronic conditions, and over 50% of U.S. physicians actually report their patients have difficulties with medication costs. So again, I highlight some of this data to again kind of speak to critical areas where there really is a need for pharmacists who I believe have been specifically trained to help ensure proper and safe and effective and affordable medication use and monitoring. The pharmacist's role on the care team. So we truly are recognized as healthcare providers and essential members of that team. And we do support patient-centered medication use by providing a number of core functions that have already been kind of addressed today. So one of those is comprehensive medication reconciliation and review. So speaking with your patients, figuring out how they're taking these medications, what they're taking, what they're not, to make sure that we're creating an accurate medication list. Doing a thorough assessment of appropriate medication use. So not just looking at the patient's behaviors of how they're taking these medications, but also making sure we're doing a drug-drug interaction screen, that we're looking for contraindications, making sure that medications are appropriate based on things like the patient's kidney function. Once we have this information, we can then, of course, develop a medication care plan and make sure that care plan is documented and communicated effectively to the primary care provider to make any necessary changes. So with this evidence that is out there, so that primary literature that's truly supporting the benefit of having a pharmacist on the care team, pharmacy services were integrated into our primary care network at UC Davis. This initially started as a 2-year pilot in August of 2014, so you can see that was 4 years ago, so we have moved on from our pilot status, which is exciting. And initially it did consist of just 2 pharmacists, including myself and a pharmacy technician. We were initially located at 7 of our 11 UC Davis Patient Center Network, or PCN, clinics. And with our implementation, our hope was to expand clinical pharmacy services. So by physically being located at the clinics, we started with face-to-face in-clinic pharmacy visits. So a schedule and template was actually opened up for us to start meeting with patients. We did utilize 2 P&T-approved collaborative practice agreements to help with diabetes management and also specific cardiovascular issues, so hypertension and dyslipidemia. And we started a prior authorization service with the help of our pharmacy technician. So we took that workload off the clinic staff and we're actually directly involved with completing the prior authorizations in a timely manner so patients got the medications that they needed. I also want to add that the addition of the pharmacist to the care team helps support UC Davis's NCQA recognition as a patient-centered medical home. So the goals of our pharmacy pilot, so we had a few. The first was to make sure that we were meeting defined chronic disease state metrics, so those specifically targeted patients with uncontrolled diabetes, hypertension, or dyslipidemia. We were able to do this again through our collaborative practice agreement, so we could initiate, modify medications based on patient-specific and, of course, evidence-based goals. We could also order labs for those disease states under our collaborative practice agreements and conduct medication monitoring. We also wanted to work to identify and aid in resolving medication use barriers, which I, again, strongly believe that this is an area where pharmacists can have a huge impact. We've been doing this by, again, providing comprehensive medication reconciliation and review, also assisting with medication access issues and cost concerns. So when we're meeting with a patient and finding out that they can't fill something and it's being left on the pharmacy shelf because they can't afford it, we're working with their insurance company, changing their Part D plan, signing them up for patient assistance programs, using copay cards, or whatever we can do to facilitate improved access and increased adherence. And we also, of course, offer medication and disease state self-management tools, such as medication bubble packing. Finally, one of our goals was to make sure that we were delivering extensive medication education and patient-specific counseling on medication use. So this is just a list of our kind of daily activities at the different clinics that we were located in. What I specifically want to highlight is our clinic time. So when we were located in the clinic, we were quite lucky during our in-clinic visits for an initial visit to be 40 minutes. So that gave us kind of the adequate time needed to complete that comprehensive medication reconciliation and review. In addition to being physically located in the clinic, we also had designated time for telephone follow-ups to allow us to kind of conduct disease state monitoring and address kind of the issues and problems that come up when it comes to medications. And then, of course, we also had our outreach duties to make sure we're kind of adequately monitoring and taking care of our clinic schedules and templates. So with the start of our pilot, we, of course, wanted to look at and evaluate the outcomes that we saw with the patients that we connected with. So to do that, we actually conducted a single center matched retrospective chart review that was recently published in May. The patient population that we looked at was type 2 diabetics seen during a 13-month period between October 1st of 2014 and October 31st of 2015. And inclusion into the study was not only based on an active diagnosis of type 2 diabetes, we also looked at documented engagement in care. So our patient populations were stratified into two groups. So we had an intervention and a usual care group. And to kind of check and document that they were engaged in care, they had to have at least 2 or more kind of encounters with either the pharmacist or the PCP, depending on which group they were stratified into. So you can see here kind of the 2 patient populations that we pulled. For our intervention group, over the first 13 months of our pilot, we actually saw 222 patients. Of those patients, 95 were included in our study. I do want to highlight, though, the patients that we saw came to us through 2 different methods. So they were either directly referred by their primary care provider to begin receiving pharmacy services, or they were pulled from an EMR-generated list that we had from our patient-centered medical home PCN registry. So that list was kind of reviewed by the pharmacist, and we could see if their A1C was, for example, greater than 8, and then pull them into clinic to be seen by the pharmacist for incorporation into our clinic and help with med management. That is in comparison to the usual care group. So this group was actually pulled retrospectively from that EMR-generated list alone. They had to meet the same inclusion criteria, but they were coming from the 4 clinics that didn't have a pharmacist located within them as part of the pilot. Once we had our 2 lists, our study investigator then used random computerized selection to actually match the patients proportionally based on 3 A1C subgroups. And of course, once we had our 2 patient groups, we wanted to actually look at a set of defined disease state metrics. The first that we looked at, and what was our primary outcome for this study, was actually a bundled response score. So what we actually did, it's kind of a unique composite outcome. We wanted to see the attainment rates of blood sugar, blood pressure, and lipid parameter goals. So truly looking at all 3. And we ranked these on a score of 0 to 3, with of course higher numbers representing better control. So if a patient had a score of 3 for their bundled response score, that means they were meeting their glycemic, blood pressure, and lipid parameter goals. Those chronic disease state goals were based on the literature out there. So for A1C, we actually did recommend for goal attainment an A1C of less than 8%. That is a little bit more lenient than the less than 7% that we are sometimes shooting for. The reason for setting that bar a little bit higher was that we tended to see a more complex patient population. They tended to have long-standing diabetes and multiple comorbid conditions that oftentimes kind of supported a more lenient goal. For blood pressure goal attainment, we looked at a blood pressure of less than 140/90, and then for our lipid goal, it was utilization of a moderate to high intensity statin based on the most recent guidelines. So looking here at our primary outcome, so this is looking at that post-intervention bundled response score. I do want to highlight that there was actually no significant difference between the 2 groups in their bundled response score at baseline, but you can see at the end of the study period, 40% of patients actually had reached 3 out of 3 of their goals. So this was significant when compared to the usual care group, who had 12% of patients meeting that 3 out of 3 goal. I will highlight that both groups saw kind of positive movement and an increase in the number of patients that were meeting that 3 out of 3 bundled response score, but there was more movement in the intervention group. So we saw that roughly half, so 53% of patients actually saw an increase in their bundled response score by the end of the study. For the usual care group, that 53% actually had no movement. So we were seeing a positive positive effect of what the pharmacist was doing out in clinic. We also looked at the individual components of that bundled response score for the intervention group, which is the bar in blue compared to the usual care group. There was, again, significant improvements in A1C, blood pressure, and statin goal attainment by the end of our study period. Looking at the A1C goal in particular, so just to single that out, again, at baseline, the percentage of patients who were at goal were actually even between the